show. The first speaker on the technological frontier would be none other than Dr. Ashok Nanda. There could be no better person to start the proceedings for the day. And Dr. Ashok Nanda, as is known to all of you, is the director of CarVision Eye Hospital, a very dynamic surgeon, somebody who introduced the concept and popularized the concept of phaco emulsification in Odisha, one out of his many initiations and many popularizations. He has established concepts, he has established technologies that was far beyond anybody's contemplation when he went back to Odisha to start his practice. Right now, he obviously is the director and one of the founder members of a very reputed eye institute in the city of Bhubaneswar, and his ideas would just keep on expanding till it reaches the summit. Are we ready with the slides? His topic is going to be...
Where's my slide? Open this one.
Tips to optimize
Open it.
the outcome of Toric IOLS.
Thank you. And at the outset, I thank Anurag and the scientific committee of AIOS and OSOS for giving me this opportunity to speak on optimizing the outcome of Toric IOLs. We all know now that cataract, being a refractive surgery, we are aiming to achieve emmetropia, and in that process, right, I press this one to go forward. Okay. So in that process, we need to actually plan our surgery well and execute the surgery in perfect order so that we come out with the best surgical outcome that we desire. We can go wrong at multiple places, starting from biometry to transcription error, planning of astigmatism and marking, and many other steps which each surgeon should look into to achieve the goal. We know that about 70% of our patients undergoing cataract surgery have a pre-existing corneal astigmatism of 0.5 diopter or more, and about 30 to 40% of them have pre-existing K values of difference of 1 diopter. So toric IOL do play a very important role in cataract surgery, and studies have also shown that only 75 to 80% of our patients do achieve emmetropia, that means have a residual refractive error of 0.5 or less, and we have a scope of improvement. So to achieve that, we have to choose the right patient in toric IOLs, and the first thing is to know who are not good candidates. Irregular astigmatism, severe dry eyes, macular diseases and combined surgeries are to be excluded. Keratometry obviously plays the most important role, and you must use 2 instruments. Make sure that the results are similar, and do it before you do applanation tonometry, either with opticals or 2 instruments at least. Biometry does play a very important role. We know if at all we are doing ultrasonic biometry, then immersion is a must. But ideal is of course a optical biometry because it gives a lot of information whose accuracy is very important to choose and put in the right IOL power calculation formula. I'll just give an example of how IOL power formula does play a role. This is a patient who has a 0.75 diopter of astigmatism, and we choose SRKT formula. The IOL power is 19.5 and the expected residual astigmatism is 0.6. Whereas the same patient, if you do Barrett's calculation for this patient, the same IOL which is 19.5, the residual astigmatism is 0.92. So that means this patient does require a toric IOL. So choosing the right formula is very important, and you get those with the newer optical biometers. During surgery, all these steps do play a very important role. Good central CCC, intact zonules, choose the right design of IOL so that rotational stability is maximum, put the lens in the bag, place the IOL in the right axis, and each of these steps are to be done carefully. If you are doing a central rhexis, make sure that you are doing the right size by marking it on the cornea with a corneal marker with the Purkinje in the center. Or if you do not have that, you can follow the pupillary margin and make it 5 millimeters, not more than that, so that there is a 360-degree overlap of the axis margin on the IOL. If you do not, if you have only a caliper, you can just put 4 caliper marks of 5 millimeter apart. If you have access to a digital marking system, obviously that's the best. You need to do the reference marking properly with a slit lamp. You have to, this is not playing, I think. Yeah. So you have to make a horizontal slit. Right. So you need to make a horizontal slit and let the slit go across the pupil over the Purkinje reflex so that it is central, and you mark both the limbus, and after that the patient is shifted to the OT and you have a marker to put the reference marks on the cornea. I'm sorry, the slides are not playing. So we also then have access to a digital marker. In that case, it is much easier. So before you put the lens inside, make sure that the antechamber is thoroughly washed, no viscoelastic left. Allow the haptics to open up and then put it in the right plane and then hydrate, not too much, not too less. So follow-up is important. You must make sure that the IOL placement axis is correct at day 1 and day 7, and inflammation control, NSAID are a must. So to summarize, choose the right patient, focus on accurate keratometry and biometry, choose the right IOL calculation formula, good central CCC with 360-degree overlap of the lens, and in the bag placement of IOL, and rechecking your axis alignment on the table 1 day and 1 week after the surgery does give you very good results. Thank you.
Thank you, sir. Just one question is allowed. Please.
So can you say, to have a optimized toric results, do we need advanced technology?
Yeah, that is a good question. See, there is something called perfection. So you can do toric IOLs if you do not have an optical biometer, as I said, with a immersion. Your keratometry has to be good. So you must at least have a manual keratometer or a autoref keratometry, and make sure that the K values are similar with similar axis. Posterior K does play a role in majority cases. It may not, but in some cases the posterior and anterior K derivation with a thin lens optic formula will be probably you can escape, but with a thick lens IOL calculation formula that may actually become wrong. So ideally yes, but still in 75 to 80% of cases, even if you do not have an optical biometer or a digital marker, you can still achieve your target.
Thank you, sir.